Welcome to AETCM. Today we're going to discuss a case about one 73-year-old man who came with complaints of fever with cough for past 2 weeks associated with breathlessness. Shall we begin, sir?
Yeah.
So on initial examination, patient was conscious oriented. Coming to the primary survey, air was patent, no secretions noted. In breathing, but airatory was bilaterally equal, but respiratory was 26 per minute and saturation of 90% in room air.
Okay.
In circulation, BP was 180 over 80 mmHg
Okay.
with pulse rate of 110 per minute.
Okay.
And in disability wise, GCS score was full and pupil was bilaterally equally reacting to light. In exposure, temperature was she was normal temperature and GRBS of 375 milligram per deciliter initially.
Okay. So just debrief. We have a 70-year-old male who has come with cough, breathlessness,
fever.
and fever. So SpO2.
SpO2 initially on room air 90 maintained in with tachypnea.
Okay.
26 per minute. And the BP was also on the higher side.
Okay. What all you did in the after your initial assessment?
So initial assessment, tachypnea was there and saturation also on the lower side. We gave him initially O2 was given in nasal bronch. Via nasal bronch we gave 4 little O2.
Okay.
And tachypnea reduced and which came on to 22 per minute and saturation also increased to 94%.
So saturation improved to 94 per minute, 94%, and respiratory rate also came down. So you have a patient with fever, cough, breathlessness. Since how many days?
This was for about 2 to 3 weeks, sir.
2 to 3 weeks. Fever, cough, and breathlessness.
And the history is that he had these complaints, went to nearby hospital.
Okay.
And therein which found that in X-ray was showing left-sided consolidation and that means
Referred here for further management.
Okay.
Okay, that we will discuss in the secondary survey. So, what all things that you have done is started him on oxygen, and will you start him on an NIV at this point of time?
But before everything, we'll have to just make sure that the patient is not a COPD patient.
Okay.
Elderly male, possibility of COPD is high. So, if at all patient has increased work of breathing, and then we can go for NIV. Otherwise, a preferable option would be a HFNC, considering the work of breathing.
Okay. So, whatever be the reason, one thing you have to settle down his respiratory rate, and we have to improve his oxygenation. So, you would have asked for an ABG at this point of time. So, can you tell the ABG findings?
So, in ABG, he was showing his pH was 7.48 with PCO2 of 32 and bicarb of 24.5.
PO2.
PO2 of 69.
69 after initiating O2. So, still he is in hypoxia only. So, PO2 of 69 with 4 liters of O2, he is in hypoxia only. Or whether it was taken before O2?
After starting O2.
After starting O2. Just starting after O2. Okay. Okay, fine. So, X-ray?
X-ray was, we also took an X-ray, sir, from our side, and the X-ray was showing a left side, upper side, upper lobe and lower lobes upside showing consolidation.
Okay, so it has a left lobar consolidation, pneumonia for ECG.
ECG was showing, ECG showing wide complex tachycardia with the pulse heart rate of 105.
105. So this patient had a tachycardia of 105 and ECG was showing a wide QRS tachycardia. What is the morphology? RBB morphology or an LBB morphology?
LBB, sir.
LBBB morphology. So what are the reasons for an LBB?
Sir, can be a previous LBBB showing the same morphology as well.
Okay.
Or else can be a new onset LBBB because of an
acute coronary syndrome.
ACS.
So LBB can be a new onset or can be an existing LBB. Left bundle branch block. It can. If it's a new onset LBB, we have to take it as an ACS. So he has a heart rate of around 105 beats per minute. Okay. So patient probably having a pneumonia, left-sided consolidation. Come in with type 1 respiratory failure. He is not in type 2 respiratory failure. You started him on oxygen And what are the other things that you need to do for this patient?
Sir, BP was also on the higher side, and on further in case it's known that he hadn't taken the regular medication also.
Okay. Maybe hypoxia, all those things together would have increased his BP, exertion, all those things. So you gave him his due medications. Then what are the other steps? You have a patient with fever, cough, breathlessness coming to emergency room. What are the basic things that you need to do?
So for initially breathlessness, and we have already given the oxygen.
Okay.
And for fever, we had to give
Fever, you have given paracetamol. Okay.
Then we had to take an ABG.
We have done that. What is the lactate level in it?
Lactate was 1.3, sir.
1.3. Okay. There is no hyperlactemia. Okay.
His GRBS was also on the higher side, sir.
GRBS was on the higher side. Is a known diabetic?
Yes, no.
Is a known diabetic. Okay. What is the GRBS?
357.
357. Since there is no acid-base disorder, we have ruled out a DK also. Otherwise, it can associated DK also can be a possibility. Then, what are the other things that you need? You have measured lactate. There is no hypotension. What will be the next thing that you have to do in the ED when a patient with sepsis has come?
So BP.
There is no hypotension.
Then
basic thing. Blood culture.
Blood routine
You have to do a blood culture and start him on a broad spectrum antibiotic. Within the first 3 hours, you have to do that. That's basically the sepsis bundle. So for all suspected sepsis, you have to do this. But with septic shock, you have to be a little bit more faster. Maybe with 1 hour itself, you need to start him on an IV broad spectrum antibiotic. So what was done for him? Whether he was started on any IV antibiotics, blood culture?
He was routine blood investigations were sent, and which was showing elevated
CRP. Antibiotics.
And antibiotic was started. Ticaracillin was started, sir.
With clavulanic acid was started. Okay. Then what happened to him?
So further, we are monitoring him, and his BP and total counts and CRP began to come down, and also further for further evaluation.
He was admitted.
He was admitted, and his secondary survey was known to have. He was a known case of lymphoma.
Okay.
And diabetes, hypertension.
Okay. So known case of lymphoma with diabetes and hypertension. So we'll just debrief the case again. We have an elderly male who has come, who is a known case of lymphoma, diabetes mellitus, who has been treating for a pneumonia in the outside hospital for the past 2 to 3 weeks. Now he has come to you with worsening of the pneumonia, not improving, with type 1 respiratory failure, no evidence of any hypotension. ECG showed an LBBB with a heart rate of around 106 beats per minute. And you have started him on oxygen to decrease his work of breathing and to correct his hypoxia. And you have started him on a broad spectrum antibiotic, ticaracillin with clavulanic acid. Okay. And he got admitted in your ICU. Then what happened to him?
So the ECG, first when we saw LBBB, we had to check if it was a new onset.
So how will you differentiate an LBB with MI? So that will be the next thing. LBB, already there is an existing LBB, or whether it can be a new onset LBB, we don't know. So whether it is a new onset LBB, it is definitely an MI. If it is not a new onset LBB, already has got an LBB. Now he has developed an MI. How will you know that?
We send the cardiac enzyme.
Okay, by ECG finding, I am asking you. Scarbosa criteria. So what are the points in Scarbosa criteria?
Concordant ST elevation.
More than
3 mm.
More than
V1, V2, 3 mm.
Okay, then. What will ideally happens in an LBB? What will be the ideal ECG finding in LBB?
White complex QRS will be there.
ST?
With ST elevation.
ST elevation will be seen in an LBB. But instead of ST elevation, you are seeing an ST segment depression. So that is one. You can't remember Scarbosa criteria. You remember that whatever being positive, you are seeing negative. That is one indication that this patient is having a myocardial infarction. So that is one thing. Already there is an existing MI, and on top of that, it is reversed, or else the ST is significantly elevated. The ST is significantly elevated in the ECG, then you can again consider that this patient is having probably a myocardial infarction. So one is by ECG finding, and other is always by your clinical examination, your history wise. The patient is having a typical pain. And third one, you can depend upon your cardiac enzymes, depending upon the time of onset of chest pain. So these are the things that you can remember. Okay, then continue. What happened to him?
Further, we evaluated for the cause of the breathlessness cuff, and HRCT was also done, sir.
Okay, so it's a pneumonia. Why he's not having not resolution of the pneumonia? Whether it is a necrotizing pneumonia, whether it has taken to an empyema, what has happening exactly to him, we wanted to know. So we went ahead with an HRCT. Just all else we wanted to know whether it is the disease progression itself, whether the lymphoma itself is worsening him, whether any new mediastinal lymph node have occurred. All those things we wanted to know. That is the reason why we went ahead with an HRCT chest. And what was the finding?
HRCT chest was showing consolidation on the left lobe of the lung with minimal pleural effusion, and also there was showing enlarged lymph nodes, mediastinal and abdominal lymph nodes.
Mediastinal and abdominal lymph nodes. Okay. So our possibility here, on a background of lymphoma, it can be a disease progression also on top on with an add-on supra-added pneumonia. So we have to keep consideration of probable lymphoma reactivation also in this patient. Okay. Then what happened to him?
So further routine evaluation showed that he was having enlarged axillary lymph nodes also.
Okay.
And we are stabilized him. Right now his CRP is coming down.
What happened?
Second day, sir,
On second day, what happened to him?
his symptoms worsened.
Okay.
Wherein he had in the night he also had one episode of fever spike, and his heart rate increased to about 150.
Okay.
And we took a repeat ECG which had different changes from our initial ECG.
Okay. So can you explain that? What happened on day 2?
Day 2 he was having raised tachycardia with he was having tachycardia and chest discomfort. We took an ECG which was showing white complex tachycardia with irregularly.
So you got a white complex tachycardia. So let's see white complex tachycardia with chest pain. So what are the, as per the ACLS algorithm, how you should go about to see a white complex tachycardia?
It's whether we want to know that whether it's regular or irregular.
I am not concerned whether it's a regular or irregular at this point. Now you are seeing a white complex tachycardia. What will be the next question in your mind?
VT
Pulse
is there or not?
Stable or unstable? Simple thing. You don't complicate things. Stable or unstable? What are the signs of instability? Which are the signs that you can say that this patient is unstable?
Chest pain.
Chest pain. He had chest pain.
Yeah.
Yeah. Then
Any past history of any heart disease?
not past history.
Cardiac failure.
Features of cardiac failure, hypotension, and altered sensorium. So whatever is affecting the perfusion. So if there is any problem in the perfusion, that means there is an altered sensorium, decreased cerebral circulation, decreased coronary circulation causing chest pain, cardiac failure, and hypotension. If any of these 4 things are there, this patient we can call it as an unstable ventricular tachycardia or unstable white complex tachycardia. Ideally, as per the algorithm, if the patient is unstable, what is the treatment? The treatment is cardioversion. So that is the, as per the guidelines. But for every patient, we cannot just go ahead and shock the patient. So we have to see real instability, maybe hypotension, and the patient have decreased response. You have to go ahead and do a cardioversion. But otherwise, you can give a trial with a drug that can decrease the heart rate. Or our aim is to decrease the heart rate, not to make the rhythm normal. Can give a rate limiting drug to decrease the rate, but the drug of choice usually will be amiodarone, which has got very good rate control as well as rhythm control effect also. So that will be what you have to do when you have a basically stable white complex tachycardia. Unstable, ideally it is cardioversion, 100 to 120 joules or 150 joules you can give. So that is the dosing as per the ACLS algorithm. Now my question here it is, how you said that this patient is having a white complex tachycardia? What are your differential diagnosis for a white complex tachycardia?
So white complex tachycardia can be.
He is having a sepsis at this point of time. So sepsis itself can cause some amount of myocarditis. So that can also increase the heart rate. So when you are having a white complex tachycardia, what are your possible differential diagnosis?
It can be VT.
Okay. One is ventricular tachycardia.
Then can be torsitis pointus.
Torsitis pointus, okay.
SVT with aberrancy can be.
Okay. What do you mean by SVT with aberrancy?
So SVT with aberrancy is condition with it will mimic a VT with the white QRS complex.
Why this patient is having a white QRS complex? That is my question. Suppose a patient is having a sinus tachycardia. Okay, and this patient is having a wide QRS. So, which are the conditions they will have a wide QRS? A patient with underlying LBVB, patient with underlying RBBV. These things they will have a wide QRS complex. And if they have got an accessory pathway like WBW syndrome, all those things they can come SVT with an aberrancy. They can have a wide complex. So, how a VT is formed? That is why you have a wide QRS complex in an ECG for a ventricular tachycardia.
The rhythm which is will be started with the ventricle, not from the SA node.
Okay.
That
See, ideally, yeah.
There's a delay in ventricular depolarization. So QRS complex is basically that denotes ventricular depolarization. So whenever there's a delay in the whole impulse because of a block or because of an accessory pathway, if there is a delay, then for the depolarization to happen, it takes a longer time, which is why you'll have a wide complex.
The simple thing is that when you have a normal conduction system, from SA node an impulse is generated, it goes to the AV node, and from the AV node to the bundle of His, and both the ventricles are simultaneously stimulated. Okay, that is the most key thing here. Simultaneously stimulated, and you have a QRS complex. So you have got a normal QRS complex. Suppose this patient is having an LBVV. So left side there is no conduction. So what will happen? The impulse will first go to the right ventricle. From right ventricle, it will go to the left ventricle and it will get stimulated. So the time taken for the ventricular depolarization is more. So as a result, you are getting a wider QRS complex. Same for RBV. So right side it is blocked. So from left ventricle, the impulse is getting generated and is going to the left ventricle, so to the right ventricle. So that is what is happening in LBV and RBV. That is a reason for a wide QRS. So for example, this patient is having a scar, a post MI scar. Suppose he has got an left ventricular MI before and he has got a scar in the left ventricle. So what it will mimic like?
it will make LBBB. Left ventricular scar. So a left ventricle will be blocked.
It is not there.
Not. So,
But the impulse is getting generated from the left ventricle. So from the left ventricle, it is going to the right side. So it will mimic like an RBVV. You understood? When you have got an impulse that is generating in the left ventricle, it will generate an RBV. When if it is from the right ventricle, it will have like an LBV morphology. So that you have to be very clear, because an impulse is getting generated from the ventricle. Because of the scar. Left ventricle there is a scar. From there an impulse is getting generated. So that impulse is traveling to the right ventricle. So that is taking care. So it is something similar like an RBVV. When there is a scar in the right ventricle, the impulse is traveling from the right ventricle to the left ventricle. So that is why difference. LBV, RBV morphologically I am telling you. Understood? So that is the reason why you get a wide QRS complex. Now we have to differentiate whether this patient is having an SVT with aberrancy or this patient is having a ventricular tachycardia. That is our question. So the simple thing, who doesn't know anything, okay, the patient, what we used to teach that the patient is unstable and you are seeing a wide complex tachycardia, you treat like ventricular tachycardia. That is for an normal people who doesn't know how to differentiate between an SVT and a VT. But when you have a postgraduate, when you are doing this, you should be able to differentiate between an SVT with aberrancy versus a ventricular tachycardia. So how will you differentiate both?
So we can differentiate this both with the help of there are many criteria.
Simple things you can tell.
So there is that Brugada criteria is one of it.
Brugada's criteria. Okay.
So there will be absence of RS complexes in VT. That's there will be only positive concordance or negative concordance.
Okay. There will be only one side. Only either it will be positive waves or it will be only negative waves. If you are getting both these things, it is unlikely to be a ventricular tachycardia. So if it is a positive or a negative concordance, it is more in favor of a ventricular tachycardia. So that's the one easy thing. Just see the ECG, and from just seeing the ECG, you can tell. Next.
Yes. If at all there is an RS pattern,
okay,
then we have to look for the time period of the same.
R to S nadir distance. The time taken for the R to S nadir distance. So, if it is more than
100, then
100 milliseconds, it is more suggestive of ventricular tachycardia. Then
if at all the RS R2S nadir is less than 100, we have to check for whether there is any AV nodal dissociation.
AV dissociation. Can you explain what you exactly mean by AV dissociation?
AV dissociation is in which atrial impulse and ventricular impulse simultaneously will reach the AV node.
They have no connection.
no connection to each other, and both will produce
Both will be each will produce its own wave, but it will not have ideally a P wave should be followed by a QRS complex. That is how it is normally. So they will have a coordinated movement from an SA node, and impulse is generated that is transmitting into the AV node, and the ventricle is getting contracted. So we got a P wave in your ECG and a QRS complex. So each P wave will be followed by a QRS complex. When you call it as an AV dissociation, what exactly means is that there is no association between the atria and the ventricle. So atria is contracting by its own and ventricle is contracting by its own. So how will you differentiate? Ideally, each P wave you should be able to see a QRS complex. But here, what will you see? Sometimes you might see a P wave, sometimes you might not see a P wave. But if you see a P wave, it might be buried inside this QRS complex, or it will be seen after a QRS complex also. So all those things you have to see. So AV dissociation, one key feature of your ventricular tachycardia. Then
you can see capture beats and fusion beats.
Can you explain what exactly is capture beat and what is fusion beat? How will you differentiate in the ECG?
So capture beat is in which there will be the SA node will be capturing the sinus of the.
See, the normal impulse pathway is happening. Normal pathway is happening already. So every time you might not be able to see a wide QRX. Sometime you will be able to see a normal P wave and a QRS complex. So it will be just like a normal one. If you are able to see a normal one, that is called as a capture beat. Fusion beat is what?
In which there will be both of them will be simultaneously
merged together. So an impulse is coming from the SA node and ventricle is also generating an impulse. So both will fuse together, and this ECG, this QRS morphology will not look like a normal one and will not look like a VT one also, something in between. So it like crossover. So in between SA node, an impulse is coming and it is fusing with the impulse getting generated from the ventricle. So that are together, and that is called as a fusion beat. So fusion beat, capture beat, AV dissociation, positive concordance or only negative concordance, these are all suggestive that this patient is having a ventricular tachycardia. Then about axis.
Axis will be extreme axis can be northwest axis can be seen in.
So how will you say that this patient is having a northwest axis?
In northwest axis, that there will be the 1 and the AVF will be negative.
Okay, so that is
along with AVR will be positive.
Positive. So there is one simple thing by seeing just at the axis. You can tell if it is extreme axis. When you have the score, this is the extreme axis. When you plot on the axis chart, so that extreme axis, it is suggestive of that this patient is having possibly a ventricular tachycardia. So why you want to differentiate between a VT and SVT clinically? Why you should differentiate?
So treatment
differs. So treatment differs. So what is the treatment if you are treating an SVT with aberrancy? What is the problem when you are giving certain drugs? What can it happen? For example, you are treating a WPW syndrome.
So if at all verapamil is verapamil deoxin is sometimes contraindicated in WPW syndrome.
What will happen? They will have
Basically, the calcium channel blockage.
Okay.
And they work predominantly on the AV node. So basically, when we give verapamil in WPW syndrome, it's an accessory pathway syndrome. The AV node gets blocked, and then there will be excitation of the accessory pathway, which can again lead to arrhythmia.
So that is one thing. So that information is very important. Any harm in giving adenosine? You have a patient in VT. Any harm in giving adenosine? You can give adenosine and see whether it is an SVT with aberrancy or whether it is a VT. You can just give a trial of 6 mg adenosine and see what is happening to the patient. So that is one thing. If you don't know anything, you can try. And the safer option will be an amiodarone in that situation. If it is a VT, you can just give amiodarone. But again, in WPW syndrome, it can also create problems. But this information is very important. You have to differentiate between an SVT with aberrancy and a VT alone. So what was the ECG finding for him?
ECG finding was showing VT at that time.
VT at that time. And how will you manage a VT? We already discussed. Stable and unstable VT, we have already discussed. So the important key message here will be all wide complex tachycardia need not to be a VT. It can be SVT with aberrancy also. So the previous teaching was if the patient is stable, it cannot be VT. If the patient is unstable, it is VT, but you can have stable VTs also. You can have stable VTs also. So VT is one thing you can have in cardiac arrest. You can have unstable VT. You can have stable VT also. So the treatment varies at each point of time. When we have in the cardiac arrest, the treatment is defibrillation. When it is an unstable VT, the treatment is Cardioversion. Unstable VT is cardioversion. And arrest, it is defibrillation. And when it is a stable VT, drug of choice is amiodarone. So these three things you should know. And to conclude, what is accelerated idioventricular rhythm or slow VT?
This is occur following revascularization.
Okay, good. Revascularization. The thing is that when you tell VT, usually the heart rate will be above 150. That is a usual dictum. But in a patient who you are thrombolizing or you have done a revascularization following an angiography, you can have a reperfusion arrhythmias, and among the reperfusion arrhythmia, the most common one is accelerated idioventricular rhythm, or otherwise we can call it as a slow VT. Why we are calling it as a slow VT? Because the heart rate is less than 150. So whether it is good or bad?
But
It is good for the patient. It is actually showing the perfusion is improving. That is why that irritability is coming and they are having this accelerated idioventricular rhythm. So that is one of the reperfusion arrhythmia. Previously, we used to see a lot of following thrombolysis, but now when we are not doing much of a thrombolysis, they are going to the cath lab, we are unable to see these arrhythmias in the ED. Previously, when we were thrombolizing with streptokinase and all, we used to see these reperfusion arrhythmias. So that is again, it is otherwise called as slow VT. What is torsade?
torsade is
Basically, a thread
long.
that is wound around the axis.
Axis, wind around the axis. So you will have polymorphic. You have different morphology of the QRS complex. One can be positive, one can be negative. Polymorphic ventricular tachycardia, drug of choice?
Magnesium sulfate.
Magnesium sulfate is the drug of choice. So magnesium sulfate, drug of choice for torsitis pointus. Okay, so how is the patient now?
Patient is improving, and
Okay.
right now the aberrancy, everything has been
He is having a sinus tachycardia right now, or normal heart rate.
normal heart.
The heart rate has come down. So the key message here it will be you have to differentiate between an SVT and a VT, because the management aspect totally differs and some drugs is contraindicated. You create more problem to the patient. Okay, fine. Thank you.